Take it from the top.
All right. Okay. All right, so our presentation's on the nurse's role and advocacy during end-of-life care. This is for Nurse 450, Nursing Leadership and Professional Issues, presented by Jacqueline Alvarado, Stephen Foth, Kiana Fenty, Damon Thomas, and Miriam Yanez.
So we chose this topic because death is something that everyone must do, yet it's still a topic that's still uncomfortable to deal with in the healthcare profession. This is evident in the topic of end-of-life care, the nurse's own personal feelings and apprehensions regarding end-of-life, as well as a lack of support from leadership, all result in a lack of quality in patient care. So the definition of what is end-of-life care? End-of-life care is a term used to describe the type of care and support patients during the time surrounding death. The goals of care are usually the focus on quality of life and to prevent or relieve suffering. So during this time, the goals of care have shifted from finding a cure to focusing on means of comfort. And also physical comfort, emotional needs, and spiritual needs all must be addressed. Next slide. So in relation in end-of-life care and nurse advocacy, nurses must be competent in end-of-life care to fully advocate for their patients. Advocacy is considered a core competency of the professional nurse. However, nurses tend to be underprepared to handle end-of-life care. And this is a result of barriers that might include limitations in school curricula that teach death and dying courses, conflicts in policies and practices in health organizations, and also different interpretations of legal jargon surrounding end-of-life care. Next.
So the position statement that we have here is nurses are not properly equipped to deal with end-of-life care due to lack of leadership support. Nurse leaders should promote increased education to help nurses overcome barriers related to end-of-life care to maintain quality care in the acute care setting. So basically, nurses need to be knowledgeable about the palliation and symptoms of the social context of death. Nurse leaders can start this education in like pre-nursing courses or nursing courses themselves, new grad programs, and even types of continuing education programs for employers.
So some data that surrounds some of end-of-life care are easily kind of separated into these two categories between patients and providers. Notice that most of these comparisons are only between patients and providers and not including the family. As you can see here, patients, 86% of Medicare enrollees would prefer to die at home. There are 29% are provided with intensive care in their final month, and 25 to between 39 die in acute care facilities, while providers showing that 40% indicated that they felt unprepared during patients' end-of-life care. 88.1% of surveyed residents or MDs reported a little to no in-class instruction at end-of-life care, mostly that they were unsupervised. Simply, most of their training really consisted of acting out in a so-called interaction with a with a patient, and it never really considered the in-depth questioning of guiding these patients into more quality of life decisions and really empowering the patient. Next slide, please. So as the nurse, it's our role to really be vitally connected with the provider and the patient, and including the family at the same time. We're really tasked with coordinating a lot of the care and the comfort during the entire process. It's important for us to be advocates and really represent the interests and desires of the patients. While we do that, it's really important that we follow the ethical guidelines as a nurse, and we actually respect their values and morals that can really enhance the quality of life towards the end of theirs. Next slide, please. So as I was saying before, we are the educators, or one of the educators, when we're talking to our patients. And it's just proven that earlier conversations that are facilitated by us would enhance the goal concordant care. It would really increase patient satisfaction, and it really aid the patient's families in the coping process. It's going to help reduce suffering. It's going to eliminate the need for any sort of invasive or costly care that's unnecessary. It really provides the patients with clinical benefits that don't necessarily burden the healthcare system if we're following through and educating the patients. Next slide, please. We can overcome these barriers just simply by following a lot of the ethical guidelines that include the autonomy and informed consent. It just really calls on nurses to engage the family in decision making and really enhance our communication. So it removes a lot of the bottlenecks and rush decisions that could really affect the patient and family members in making really bad decisions towards the end and pursuing aggressive care, rather than just really taking your time to approach the quality of life and care with more thought and early conversation. Like I said, creating a framework for the nurses and the family members can both benefit, just as far as making a team approach and just really advocating at the end of life for these patients. Next slide, please. There are laws that help support the end of life care, and one of them being the California End of Life Act. This pretty much was implemented in 2016 and helps ill individuals that qualify with certain terminal illness to actually help them achieve I would say, a death with dignity. These individuals who qualify really seek the help and education of nurses and providers. And it's really important as nurses and providers that we give them this education earlier on during the process. Whether or not you may think that palliative care is a good time to talk about it, or earlier on before this patient has received a diagnosis, an official diagnosis, any time is a good time. But we should be guiding these patients into these things, and this law in particular helps these patients die with dignity. Next slide, please. There's also the advanced directives and the pulse that actually assist these patients in making these decisions beforehand. Obviously, patients can make decisions due to mental issues or incapacitation with disease. In this regards, these legal documents actually help on their behalf. So identifying a surrogate at these end-of-life decisions for the patient are really important. It just really outlines their specific values and beliefs that may or may not include a religious stance on it. Pulse actually just complement the advanced directives. They're really specific types and just carry out the really medical specific orders in treating the patient. And this, like I said, this just ensure that the patient is receiving exactly what they want at their end of life and really deserving a quality of life care rather than being rushed into a hasty decision. Next slide, please. This really reflects the outcomes as far as the basis for patient and family satisfaction. It's really important for us that we have effective leadership and communication. Like we were mentioning before, it really empowers the patient, giving a sense of control and really in honing in on actually the autonomy and ethical dilemmas that a lot of providers face, is giving that control back over to the patient, really making a holistic decision-making environment among the patients. Next slide, please.
So in regards to a leadership theory that we thought would be instrumental in solving this this dilemma would be transformational leadership. The definition of transformational leadership is a leadership style where leaders create a vision to guide change and motivate others to follow, while focusing on organizational collaboration that can help drive a vision forward. And this consists of 4 I's. The first one would be idealized influence. This means that a leader serves as an ideal role model for followers. This can be someone who would be comfortable with end-of-life care. And an example of a transformational leader from our past would be Dr. Dame Cicely Saunders, who actually founded hospice care. The next one would be inspirational motivation. This is when a leader is able to express organizational vision and motivate followers to perform in a better way. Intellectual consideration, that's when the leader shows a genuine concern for issues faced by followers and generates ideas to address these issues and includes them in the decision making. And then there's individualized stimulation, where the leader challenges followers to be creative and innovative. This would be, an example would be having someone come up with new ideas to help nurses become more comfortable with end-of-life care. Next slide. And this is just a flow sheet of just the steps of transformational leadership, where you have where it all begins with developing a vision. Next would be selling the vision, creating a roadmap, and then leading the charge of change. Next.
For our expert interview for Insight in Hospice Care, I was able to go ahead and interview Tian Yu again, nurse practitioner in palliative care services in the Department of Medicine Division of General Internal Medicine at Harvard-UCLA Medical Center. She was able to share that she obtained her degree from Charles R. Drew University of Medicine and Science. She has been a nurse for over 15 years and has spent 8 years in hospice care. So she was a great resource. She shared that she values holistic approaches to medicine, strives to ensure everyone has access to exceptional care, and her favorite part of her profession is empowering and educating patients. Next slide. For her, the keys to success are for physicians to investigate decisions around the goals of care of the patient, which preserves hope and optimism, and also reorients treatments towards appropriate aims. Palliative care should be part of a broader continuum of care, thereby avoiding abrupt changes in the medical course. Family physicians are well positioned to discuss advanced care planning during routine office visits. Several increasing distinct approaches are available to facilitate this discussion. So she shared that nurses should aim to relieve suffering by identifying, assessing, and treating pain and other physical, psychosocial, and spiritual problems of the family and the patient. Comprehension and communication are very important to her for hospice care to be a success. Next slide. She shared that the benefits for hospice are that it provides relief from pain and other distressing symptoms. They get better symptom management and quality of life compared with the usual treatment care. Studies show that patients who receive hospice care have improved quality of life with less depression and symptom burden. She shared that they feel more in control, are able to avoid risk associated with treatment and hospitalization, and have decreased costs with improved utilization of healthcare resources. She also shared that benefits extend to caregivers, family, and friends, which also further satisfies the quality of care and attention the caregiver needs. Next slide. Upon this interview with Dr. Nguyen, she shared that the same drawbacks that were mentioned before this, there is a lot of lack of education for nurses when it comes to hospice care. Without insight to it, the patient, there are barriers with the physician, the family, and as well, there's an increase in fear. She shared that patients have a number of misconceptions about advanced directives, living wills, and power of attorneys. Therefore, they need further education on that, as well as the communication and cooperation aspect of when starting in hospice care. Sometimes certain values are just not understood between them. So it's very important to have active listening skills and as well as effective communication to be clear and concise. Therefore, she also said the drawbacks are that not a lot of schools provide cultural competency in which the physicians are not challenged on learning how cultural factors influence patients' responses to medical issues. Many physicians are unfamiliar with common cultural variations regarding physician-patient communication, medical decision-making, and attitudes about formal documents, such as code status, guidelines, and advanced directives, as well as going further into explaining the grieving process, because not everyone grieves the same way. Sometimes it's also part of the drawback in which you mentioned that for some individuals, they will entirely miss some stages and some may go back and forth. And that is where also we need our nurses to be aware of. Next slide.
So how the nurse leader can support the staff is through education, extra support, and encouraging teamwork and collaboration. With education, nurse leaders can offer education or give incentive to attending trainings, do online modules, and even introduce the topic during huddles. This education will give nurses the empowerment, confidence, and moral agency to practice palliative care. Nurses need instruction on the key elements of palliative care, clarity in their role, and administrative support to take on this role. Nurses can recognize a change in patients' health status and condition with their assessments. Therefore, extra education in palliative care will give the nurses the agency they need to start the conversation about palliative care to support their patients' needs. Some examples of educational opportunities are evidence-based palliative care training programs known as End-of-Life Nursing Education Consortium, or Comfort Communication Curriculum via online modules or video conferences. Through support, nurse leaders can take the initiative to create a unit of empowerment that enhances the nurse's agency to practice their nursing skills. The nurse should feel comfortable and confident in ongoing dialogue about ethical concerns in palliative care. Additionally, they can offer support with debriefing and checking in with the nurses after a patient passes away. The nurse leader can establish support groups, training and coping mechanisms, and peer-to-peer support. These supportive measures will help alleviate the emotional strain that can come with end-of-life care and reduce burnout and fatigue, which essentially improves patient care overall. Lastly, through teamwork and collaboration, end-of-life care is a team effort to provide the best quality of care for the patient. When the nurse leader encourages collaboration amongst other disciplines, it improves the way the nurse and other disciplines communicate with one another. Improvement in communication amongst the team will eliminate misunderstandings that can occur amongst the family and patient care, their wishes, concerns, and current health status. Subsequently, the ability of teams to successfully collaborate has an impact on the quality of patient care, the experience of the family, and is an investment in staff time. This is a skill that needs to be practiced and encouraged by nurse leaders. Thank you.